Okay, good afternoon, everyone. Welcome to Ethics for Lunch, start of our academic year. We appreciate you coming. As you know, or many of you may have been coming to past sessions in previous years, Ethics for Lunch is an opportunity for us to get together as a hospital community and talk about issues that are relevant to clinical care of our patients here at the hospital. It is sponsored both by the Ethics Committee as well as the Berman Institute of Bioethics. We do offer CME credits, continuing education credits, for those that are interested. And as part of that, we need to sort of inform you about the process for continuing education. So I'll run through those, just some housekeeping stuff. So we have an accreditation, we have a point that it is we go till 1:15, so 1.25 hours of credit for CME. If you're going to apply for that, we make sure there's disclosures of any conflicts of interest. If generally it's not happening in ethics presentations, but if there are any mentions of off-label medication use, we would disclose that that's happening. We welcome everyone. So it's physicians, nurses, social workers, chaplains, nursing, medical students, community members, anybody and everybody. We want to have you come to Ethics for Lunch. And our general objectives are, again, to have an opportunity to talk about these issues. So this is both for, just CME in general, what it's trying to achieve, as well as what we're trying to achieve in Ethics for Lunch. So translate things that we know about patient safety and quality, and translate that for, the ethical care of our patients. Foster communication among our stakeholders, and then hopefully learn from cases. Often we'll include case presentations as a way to stimulate some of the discussion of our panelists. As I mentioned, we will disclose conflicts of interest. So there is one of our panelists, Dr. Myers, for today. And for today, the three things are going to be ethical conflicts that make it difficult to care for youth who are boarding in the hospital. I'll discuss two reasons staff caring for youth who are boarding in the hospital might develop moral distress, and describe two interventions that can be implemented that will reduce moral distress for those caring for youth boarding in the hospital. We have our confidentiality pledge. So generally, we will de-identify cases. We might use, case characteristics to highlight an issue that might have come to the ethics committee or that our clinicians have been concerned about. But otherwise, if there's any confidential information, the expectation is that you will keep that information private. For those that are interested in getting the continuing education credits, there is a new phone number for this academic year, the 844-980-1555. If you've not done that before, you need to go through these steps. That is also available on the CME website. I won't linger on this one, but just to know that you can, once you have an account with the CME office, that you can get the future sessions recorded. And for today, our code is going to be 51352. So if you text that to 844-980-1555, you should get a thank you message. Thank you for registering for today's meeting. More information is available through the CME website. And the other thing I wanted to highlight that there were cards that you might have seen at the lunch table there. There's a new program, a podcast that the Berman Institute is sponsoring called Playing God. So life and death dilemmas, controversial treatments. In this Playing God podcast, we hear from patients whose lives were transformed and sometimes saved by medical innovations and bioethics to help guide complex decisions. This week, it features the case of Chahai McMath, the young girl that had a diagnosis of brain death, and there was controversy about that. So you can hear all the details of this determination of death and how that gets determined. Other interesting podcasts that you'll see each month. So we welcome you to check those out. And without further ado, I'm going to turn it over to Shannon Barnett, who is going to be our moderator for today, and see if I can actually put up.
It's the one on the left. Perfect.
Okay. There you go.
Oh, it's just, okay. It's not the first part.
I'm sorry.
Good afternoon, everyone. My name is Shannon Barnett. I'm a child psychiatrist. I have a clinic at Bayview. I'm actually on the clinic ethics committee here, and then I also spend most of my time working with Baltimore State Department of Social Services. So I'm going to help kind of facilitate this discussion on youth who are boarding, so which are often youth that are involved in foster programs, but either in the hospital or ready to be discharged. But from our perspective, and we have nowhere to go. So we're getting our cases coming, but before I read the case, I'll let the panel and I'll introduce themselves.
Yeah. I am. Oh, sorry. Hi, I'm Bethany Salter. I am a general pediatrician. I'm faculty in the Department of Pediatrics in the Division of General Pediatrics and faculty at the Berman Institute of Bioethics. And I guess I'm here today because much of my work focuses on kids with complex medical behavioral needs who are in the foster care system. And I've done some work on kids who have delayed discharge.
My name is Alyssa Torn. I'm a clinical social worker, and I am here representing the Employee Assistance Program. And I think my purpose here today is to answer any questions that you might have about how we help faculty and staff while they are in the midst of dealing with complex cases.
I'm Mackenzie Summerholder. I'm a pediatric psychologist here in the Children's Center. I wear many hats, and I usually work in our acute intermediate care programs for youth, including the emergency department. I wear many hats related to this particular population, and one, along with many of you in the crowd here, we're working on a work group to develop what to do for these youth while they're here in the hospital.
I'm David Myers. I'm a former chief of emergency medicine at Sinai, and I'm currently involved in ethics at Sinai and at the Maryland Healthcare Ethics Network, where we've taken up this problem from the ethical point of view and have been working with elements of the state government and the Maryland Hospital Association to try to help them solve the problem. The legislature passed a law last April that was signed by the governor to set up a commission to examine these long stays of patients, particularly young patients with behavioral health problems, recognizing that the resources are a critical area that's been neglected.
Okay, so I'm gonna have to read this case. This is a case kind of a conglomeration of other cases. This is not a particular person, but I think issues that arise frequently. So this is Bethany, who's a 15-year-old who presented to the hospital at diabetic ketoacidosis about 5 weeks ago. Prior to her admission, she ran away from her cousin's house, leaving behind her diabetic medication. She is now medically stable, ready for discharge, but her cousin has refused to come and pick her up. Her cousin does not feel she can be Bethany safe, and no other relatives are willing to provide her care. Her background, her mother was 16 years old and in foster care when Bethany was born. So she wanted to be a parent. Bethany's mother struggled with her own mental health, and so she said Bethany's mother would often leave her for extended periods of time with various relatives. And her mother was recently incarcerated. Bethany's father Bethany's experienced transient living conditions, domestic violence, community violence throughout her life. She suffered from inappropriate sexual touching from several family friends. And she's had caregivers who use physical punishment that has resulted in injury. She's struggled in school with difficulty staying focused, difficulty learning, reading, and particularly reading math skills. She gets frustrated easily, leading to outbursts that can include verbal threats, property destruction, and occasionally physical aggression. She often stays out all night without permission, and she's left the home for over a week on 3 different occasions. She was recently diagnosed with insulin-dependent diabetes mellitus. Since then, she has struggled to monitor her medications. When she's calm and feeling supported, she can test her glucose and administer her insulin appropriately. But when she's frustrated or stressed, she makes poor food choices and does not monitor her medication appropriately. This is her second time that she's left home for several days without her medication. When her cousin refused to have Bethany return to her care, the hospital staff called Child Protective Services. The plan is to find her a replacement and then to bring her into foster care. No placement has yet been found. This belongs to a youth with diabetes and her history of running away. Bethany has been ready for discharge for over 4 weeks. While she was initially pleasant and cooperative, she's grown restless and bored, had repeated outbursts and cursing and threats with staff. On one occasion, she threatened her generator nurse. Last week, she threatened to punch a nurse who told her she would need to wait a few minutes before a requested item could be delivered. That's our case. Hopefully, some of you have seen things similar to this. So I think the first question I have, how the panel has addressed is just what are the ethical issues and everyone's kind of talking to see what ethical issues you see in this case.
I mean, I think one of the biggest challenges is just what's in the best interest of these kids. So people talk a lot about they need to be in a safe placement, but how do we think about safety, but also general well-being? And so trying to, promote good and not cause harm for these kids is really challenging when we're limited by what our placement options are. I think we can talk a little bit maybe more about that, but if lay out, I think that's one of the issues is we feel like, are we doing right by these kids? And that's balanced. I think we got some other things.
I would also say another ethical issue that comes up is the dignity of all individuals involved, in maintaining dignity, particularly when there are policies and procedures that are in place that don't capture this population of youth and make that limit access to things or put them in positions which we're stripping away what feels like stripping away rights, as well as practicing confidently, right? Many of our ethical codes, confident practice is part of it. And I think we're all put in a position to practice in different ways with these youth, because we're all here to care for youth who require medical support and services, and these youth no longer do so. So those are a couple that come to mind.
I would add that there are legal obligations of the state to make sure that kids are educated, that they have access to all kinds of social resources that are going to enhance their development. And when they're captives in the emergency department, they're not getting appropriate care. So we're violating our principle of beneficence and non-maleficence. We're not providing, this, as far as decision-making goes, a teenager like this is probably on the verge of being able to make decisions if she were normal, but she clearly is not able to exercise good judgment. So there's a question about her, whether she could exercise autonomy at least by assenting to what might be recommended treatment. Her mom, who would ordinarily be her decision maker, does not have a good relationship, so the kid is kind of adrift in the decision-making aspect of things. Beyond the patient's immediate needs not being met are those of the staff who are feeling a great deal of moral distress because they're not able to give her what they recognize she really needs. And she's, on the one hand, unwilling to accept a lot of it, but it puts the staff in a very difficult position of knowing what ought to be done and not being able to do it. And a lot of the burden falls on the state for not having the resources which ordinarily would be provided to patients like this.
think, I think I heard a couple of things. One is kind of what's our responsibility to Bethany. One of the ways I sometimes think about it is society as a whole has an obligation to care for her. But one of the problems is nobody has an obligation, a personal obligation to her, right? So we have a societal obligation, but not, no one has a personal obligation, which is why from like Department of Social Services, they send out, does anyone want, will anyone take this kid? Will anyone take this kid? So every place they can take it, they actually have a list and they just send a sheet about her to everybody in the state that potentially could take her, and they all, but they don't have to say yes. So a foster parent doesn't have to say yes. And I think that comes similarly, you know, you might say, well, we have an obligation as a hospital to care for her, but then the staff, you know, when you're coming to work, you also have a right to feel like you're safe, right? So we want to, how do we care for you like this and also keep staff safe, and then placements. So I think that's mirrors that. And then I think so there's kind of what our obligations. I hear from staff, this is obviously not a great place for her to live. It's a horrible place to live. So not getting education, doesn't have the social experiences that we would expect her to have, that being able to practice her autonomy, not going outside, yes. And yes, we don't actually have so this is not a great place. Everybody agrees with the question, is just we don't have another place to put her, so it's like, so that I think creates a lot of distress and particularly moral distress.
I would say the other thing related to the moral distress is knowing that this youth who does not need hospitalization, taking a bed that could be given to a youth who does need hospitalization. We know that boarding increases all sorts of problems and concerns for people who are needing bed, and it's just a trickle down flow from our ED to emergency services in the region. And I think that that's a big thing that kind of presents as well, particularly from a moral distress perspective.
I think also like putting into the context of this, we feel it very intensely here because it's happening to us, but it's happening everywhere across the country. So if you just look in the news and type in, you know, borders, DS, or, you know, child welfare and boarding, you're going to see multiple states that in all across the country, this is the same problem. There's multiple lawsuits now in multiple states that have been brought on, including in our state by disability rights advocates or other organizations to bring attention to this and say, you know, this really isn't in the best interest of these kids to be boarding them in these hospitals. We need to come up with more strategies to improve home and community-based services for them so they can be in less restrictive settings, or for those who do need a higher level of care, figuring out how we can build capacity for that. But it's a national problem. And so when it comes to like, well, yes, they're not safe here, they're not getting education, they're not going outside, we're not being able to give them the dignity they deserve. There's other kids who are living in hotels because there's nowhere for them, or sitting in the offices of the child welfare staff. And so sometimes when you talk to child welfare, they're like, we realize it's not ideal in the hospital, but it's also not great for them to be out in a hotel, especially a kid who has diabetes and medical needs and is, you know, from a mental health perspective, might be stable right now, but is at risk of that changing pretty quickly. So we're in this really like around our place of what do we do at this national level and then at a local level to try and improve possible placements and build capacity for those in the community who can take care of these kids. And it's not a quick solution.
To that point specifically, I've been involved with the legislature. They were looking for solutions to the ER, and we looked at it from the point of view of how to reduce length of stay in ED, because Maryland has the worst waiting times for care in the emergency department. We're not ranked number 50 in the country. Our waiting times for care in our EDs is the worst. So there's a lot of interest in trying to open up beds in the emergency department, and these kids take up a lot of space and a lot of resources. So, as I pointed out, the legislature passed a bill that the governor signed to set up a commission to examine the behavioral health issues And I've been monitoring progress with this, and I called this morning to talk to the person who's running the state program. And the governor still hasn't fully appointed the commission members, of which there are 30 from all kinds of stakeholder interests, some of which are not directly related to mental health. There are some areas of mental health that aren't represented on the commission. So I've been trying to argue that the commission is not ideally set up, but even as not ideal as it is, it's still not completed in the appointment. So they were expected to give a report to the legislature in January, and I can't see much happening in the next 2 and 3 months before the legislature convenes. Now, secondarily, the Maryland Hospital Association, looking at the issue of length of stay particularly, has set up its own commission to look at this problem. And they've met 2 or 3 times and are just beginning to get into the details of it. And there'll be progress there before there is a state commission. The one other comment I would make about what's been said so far, this kid is so complicated. We talk about ideally looking for best interests, but to try to establish what that would be, if we could establish that, it would probably be impossible. And I think from an ethics point of view, you might be looking at a least harms approach to minimize the harms to the child, because as we point out how lacking the resources are. So what is the best we can do for this kid? We know it's not going to be ideal.
Yeah, I hear a lot of times people saying, well, if she's in a long facility, then at least we don't try to go into diabetic ketoacidosis, right? But if she's in a long facility, she doesn't have relationships, she's, yeah, whether or not she eats better, kind of general standpoint, you know, she autonomy is kind of restricted. I think someone then hand up.
One of the other things is now she's 16 and she's gonna be 18 very, very quickly. And, you know, the ability to impact that in such a short period of time with all the trauma she's endured up to, feels very defeating. You know, unable to impact.
That can contribute to moral stress, kind of feeling like we have the clock is ticking, she's gonna turn 18. So, and I do hear that sometimes with that, we've got to fix this now, because if we don't fix it before something turns 18, I feel like we have less team involved. Although I think sometimes, I mean, she's pretty behaviorally dysregulated, so how much control we have now, but it's probably what to do.
I mean, we had to fix it like 12 years ago. That's, you know, the problem is we have so many challenges getting kids like more preventive mental health care in the community from an early age, or just supporting families. I mean, this child was born into her mom very young, and mom didn't foster care herself. I mean, this multi-generational trauma and breaking that. And, you know, so I think people look to right now, like, how do we do a quick fix? Because this is this big problem. This isn't a new problem. This problem has been going on for a long time. I think it's came to a head more so with COVID and mental health crisis and providers leaving the field. So then there's more provider shortages. There was the Family First Prevention Services Act, which passed 5 years ago. I don't know if people are familiar with that, but that was federal legislation, which I think was very well intentioned to try and put more money into prevention. And as part of that, wanting to decrease kids in more restrictive settings. And so unfortunately, what happened was some trying to change regulations of, you know, how many days you pay for a kid in child welfare to stay in a group home, or qualifications needed for group homes or residential programs, is some shut down. And so I think what was well-intentioned kind of came to head with multiple policies all at the same time, and COVID, that this was a problem that predated COVID. And now it just got so much worse in the midst of it. And there can be band-aids on it, but I think really thinking of the broader system supports that need to go into prevention and building up families, like much before this happens, also has to be part of the discussion.
Yeah, and I think to your point too, right? So like, and I think Rachel, what you were saying as well, is like this kid has grown up in this system that has predated her, has impacted her mom, right? And then we're seeing this kid in this very brief, feels like a long moment, but a very brief moment nonetheless in her life, or this issue's life. And then it's creating a lot of conflict within disciplines and like staff morale around what are our expectations, what are reasonable expectations, how can we support this youth? What is meaningful change? What is keeping her safe? What is keeping her healthy? What is keeping staff safe? What is keeping staff feeling competent and productive in their workplace? And it kind of like all accumulates in this sort of like one moment in time, but it's a huge issue that then gets difficult to think about when you're like really acutely living in moments when she's threatening to harm you or when she's in DKA.
Looking from the institutional level, you know, how soon can a remedy occur? Actually, the impetus now is to cut back on inpatient beds and not to commensurately raise outpatient resources. I can't imagine what the numbers of these kids are, how many in Maryland alone. The legislature will probably be a 2 or 3 year process before they can come up with a legislation of funding, and whether that funding will be adequate, whether the public will tolerate taxes and changes in taxes or things like that. I'm afraid I'm not optimistic.
So, hi. Okay, I'm Bethany Gross in this program. This is my first time coming, so I hope I know this is a hypothetical case, but it didn't look like they were getting a psych evaluation. In other words, a lot of behaviors and suggests that this person is experiencing tremendous depression and perhaps anxiety, PTSD, and it seems that this is potentially a missed opportunity to get a very thorough psych evaluation and develop some intensive psychotherapy action. I mean, to use this time because if she goes out into the community, that's going to be a lot harder for her to get those kinds of services. So I just want to add that as a component, because this seems to be the base of why the relatives won't take her, and perhaps nobody. I mean, she would be hard to place. What do you think?
What happens?
Gosh, that's such a really, really good question. And Dr. Barnett, you probably know more outside the institution than I can speak to what happens here once a child is in the hospital. So I don't know if you wanted to take.
I think first say what happened in the hospital.
So once these kids arrive to the hospital, there are like a couple different. Can you guys hear me? Okay. Okay. Thank you. There are a couple different mechanisms in which these kids end up arriving to the hospital and then sort of living or boarding on our floors. And when I say floors, it could be any of our floors. And I know many of you guys have had experience and exposure to these youth. Often these youth come in through the emergency department, usually because their current placement is no longer feeling as though they can care for that youth, but there are also many other reasons. Sometimes these youth come in for medical reasons or psychiatric reasons, and then once it's been medically determined to be able to leave the acute setting, right? Maybe the medical reason or the psychiatric reason isn't totally resolved, but it might be more of a chronic concern that doesn't require acute hospitalization. But then sort of are in this waiting period for finding a place for them to go live. So those are the mechanisms. The tricky part in our hospital currently is that psychiatric and psychological support is on a console basis. So we have psychologists and psychiatrists here within the hospital who are dedicated to different services and teams, but in the acute care setting, it's console only. So we don't have the staffing capabilities at the moment to be able to do comprehensive psychological and psychiatric evaluations on the youth who are boarding with the placement, which is really sad and really unfortunate. As part of the work group that many of us here are participating in, we're working on trying to get some resources in place and do a better job at that. By and large, our social work colleagues end up bearing the brunt of gathering information, making these assessments, and gathering sort of the multidisciplinary team. But it's definitely something that's not happening here in the hospital level. Yeah.
Yeah, if she were in the Baltimore City Department of Social Services has a new program that they're just starting to roll out for youth who are in care, so she's not in care yet, but that actually have therapists that now are can start coming to the hospital. And I know Hopkins has actually allowed these therapists in, many other hospitals are not allowing that. But I think setting these kids up with a mental health provider that will see them while they're here and also transition and see them when they leave with the same person, because you just start, you know, and this is gonna take a long time for her to heal, but getting her started, I think, can be helpful. And so you know, and I think one of the things we really want to talk a lot about is, you know, I think when we're dealing with issues like this, making sure we're hearing youth voice. So when we're thinking about solutions, how do we, that's I think particularly hard at a hospital. How do you get youth voice involved in that? Those are all really good ideas. Any other people who thought about ethical dilemmas that we maybe haven't talked about, particularly those of you worked in cases like this?
I don't have a question about the ethics. I'm interested in your comment that often doesn't have a program of continuing psychotherapy support, treatment support. What is the evolution of that? How is this purely a sort of fiscal restraint that governs that?
Sure, I think that that's a really wonderful question, and I can't speak to necessarily the complexity of the answer. One of the things that I can say is that we are in need of more psychiatrists and psychologists in the children's center. And we are in need of additional resources to be able to do the services, particularly related to this youth. We are in conversation about figuring out how we can develop a behavioral emergency response team, figuring out how we can provide more supports and services from the psychiatry and psychology consultation liaison service, and how do we improve our access to staff within the children's center. But there is a bit of a staffing issue, there's a bit of a financial issue that are sort of lumped in together. Go ahead, Rachel.
So we are not reimbursing these children. So
Yeah.
there is a financial piece. We need to stay afloat, right? And understanding that, you know, we are not set up for this. So every resource we pull into one child is a very, you know, it's a loss, right? And overall, so I think that this in the community, right? Our community has shown that these youth are not important. Our government has shown that these youth are not, you know, right? And the hospital, we do the best we can. We've come up with a lot of changes recently. That we're not even talking about, but I think that, I think it is. I mean, to be honest, I'm not representing anyone but my own opinion. I think there is a financial piece to it. I mean, we are not getting reimbursed at any level, and it's just because there's no mechanism to do so.
Yeah, think about it, you have to meet criteria for hospitalization to get reimbursed by insurance. And what are we saying by definition is a youth that doesn't meet criteria for hospitalization.
And I think that some of the things that lead to moral distress with the nursing and caretakers on my unit particularly is the feeling that maybe social services, what are they doing out there, right? Like, we're taking care of the child, or are they really doing everything that they're supposed to be doing? And by us being the intermediaries, a lot of times it's like, you know, can you call my worker? Why isn't my worker answering me? You know, and we're sort of having to be the one to help the child with the coping with that. I think it's helped recently to have, and we're planning this in the future too, interdisciplinary meetings. At first I thought it would be more difficult because it would take time out of the nurses' schedules, but I find that it's more helpful because they can sort of hear what's happening behind the scenes. There's always a little bit of level of distrust. You know, our feelings really being represented to social services and what's happening here. So it gives them the opportunity to be able to see what's happening and to express things and work and feel that there is a collaboration happening. They just might not see it, but it's happening. And I think that's the hard part, is feeling that these kids were just dumped here and nothing's happening and they're being forgotten about.
Yeah, I'd like I straddle Hopkins and Central Services. I see this issue from both sides. So I think one thing that's really important to know, and one of the reasons I did this in this case is for reasons that I don't understand, she's not in foster care yet, so DSS will find her a placement, and then they're going to discharge her, and then they'll go to court, right? So she's not in placement, so she's not on this overstay list that has to go reported at now. She was already in foster care, she would be on this list, and there'd be more meetings. So that's, I think, one of the issues. I think another thing to think about is Maryland has, you know, each jurisdiction, so like each county in Baltimore City are their own social services agency, but all these programs, all the placements are overseen by the state. So if you think of the people who are trying to place the youth have absolutely no authority over potential placements. They're just asking. And so I hear that from the DSS side is where we can't make anybody, like we cannot force anyone to take this view. So that's, to me, I see that a lot of times. And so that feels like DSS isn't doing anything. They don't understand it. I hear them saying the hospital doesn't understand. We can't make it. So I think everybody's actually under moral distress. So it's like everyone in the system, not just you guys. So maybe it's shared moral distress.
So I really appreciate your point about how we feel unheard. And that the distress and the reason we're distressed is because we're not able to do what we think we could do under other circumstances. And so that weighs heavily on us. But at the same time, there's a lot of assumptions we're making about each other and about the situation that may or may not be accurate. So, you know, the point of having opportunities where we can actually verify, you know, what actually is happening. And also the limitations. I mean, there are clear limitations here on what we are able to do. And it's not because we don't fail. It's because the mechanisms are just not present for us to do more. So one of the things I wonder about is also how do we create realistic expectations of ourselves? How would we know when we exert enough effort? You know, because we keep pushing to try to make something that may be impossible to happen. And yet we expect ourselves to fix these problems that some of them have been present for millennia. And we're still expecting ourselves to fix it. So I think there's a part of this of, you know, how do we actually take account of what we have been doing. It's not because we look the other way, it's because we're looking straight into the problem. And that we are doing the best with what we know. It's unfortunate that we don't have the need to do what we feel for them.
I'm so glad you said that, right? Because when we think about all the comments, we're asking people to step outside of their training, their role, what their responsibilities were when they decided to work here, right? We have nurses who are being parents. We have social workers who are being case managers. We have and therapists and parents and all of the things, right? We have security officers who are being detention officers who are not able to stay outside of the hospital and support what's going on in between the hospital and the community, but rather having to sit at bedside and hold these kids in these rooms, right? You know, we have all of these staff who are stepping outside of their role in a way that feels really uncomfortable and taps into different sorts of parts of their theories, their thought processes. We have emergency physicians who are having to be primary care providers, right? So everybody's having to extend their role and tap into training that they may not have had. And I think that speaks to your point of like people are doing the very best that they can with what's in front of us.
I do just want to jump in and say that I do think that's where the EAP can come in really, can be really useful, because obviously on the floor, it might not be the appropriate time to process all of those feelings that are coming up, but we can provide a confidential, safe space to be able to talk about all of those things that are free of charge, you're not using your insurance, and we also use a separate medical record system, which I think a lot of people don't know. So no one is going to know that people come to see us. So it really is a safe place to come and talk about anything and everything related to the difficult cases that are in front of you.
Yeah, we will. We have a couple of slides on that because I do think I do want to. We're talking, I think right now about a lot of the kind of hopeless stuff that we do. We are planning to end on at least real steps that are being done. And we didn't just pick this so that you would all go back to your team and just be like, oh, whatever. So we do have, and so we will get to that. I'd like to, I don't know, you.
Yeah, so, one of the things I don't think we touched on, about moral distress and moral distress that was on my unit, with a case, was the other families and their lack of feeling safe. We have many babies on our unit. We're not just an older adolescent unit, we have everything, but we had a lot of babies and a lot of parents who were very scared about leaving their babies, or whatever else, and finding ways to reassure them when even the staff felt not safe all the time. I think that's a huge piece of the moral distress that we saw in our client.
Yeah, I think taking care of these youth, that's a big thing is, you know, like we need to take care of them, but people need to be safe and sometimes that's really hard.
But that's one person, and then you have all the other people, and you can't talk about that situation. Right?
Hi, I think I have a little bit conceptual question. It's about the risk harm approach. And I was just wondering that can foreseeable harm can overweight the actual harm? In this case, if we keep the patient in the hospital, we kind of really harming the actual autonomy of patients. But if we let the patient discharge, then we have a really high likely, possibility of foreseeable harm. So in this case, can the foreseeable harm actually overweight the real harm that is going on in this case?
And I think that's why this is so hard. Exactly. I mean, you said it very well. I think that's why this case is so difficult because I'm just saying something to them. I think both situations are so hard. We know, like right now, this kid is obviously not doing well. Not only are they not doing well, but the longer they're here, there is even foreseeable harm current, like staying in the hospital. Like we know probably for kids who've been traumatized, maybe aren't always getting trauma-informed care, and then they're being triggered because they're having rights stripped away from them. So kids may actually get worse while they're here, right? Is that what we're seeing? That kids may come in without having aggressive behaviors, and then the longer they're stayed locked up in a room, you start seeing things happen. So even while we're in the hospital, there's the real harms that currently exist and then continue to happen. And then the unknown of what's going to happen if they go out and go into a less safe thing is what we're worried about. So I think exactly the way you described it is what everybody's grappling with, and it's really hard to know, like, where do you balance it? It's also certain things you can't do. Like this 16-year-old, to my knowledge, couldn't just be discharged out to nobody, unless they somehow had become an emancipated minor. So it's not even an option to just send them out into the ether, and they're not in the custody yet of, like you're saying, child welfare. So this kid is the perfect example of like living in this limbo stage where literally nobody has like ownership of them to take care of them once they leave here. And that's kind of like a really, really challenging, terrifying place to be. And then the combination of the medical and the behavioral makes it more complex because there's like no places that, well, not none, but very limited places that will take kids who have like the dual diagnosis to go to programs, and then building on top of all of those fears.
I think the case that we're talking about shows us that the staff have opted the least harmful thing is to keep her in the hospital because at least she can be managed in terms of her diabetes, and the staff can be helped to adapt to the behavior problem that she exhibits, and we'll try to make a safe place for her. Once she's out on the outside, we have no idea what environment she'll be exposed to and whether any of her needs will be met. She'll be on the street or whatever. So I think we probably opted to keep her here because in our assessment, that is the least harmful, but recognizing that there are plenty of harms associated with keeping her.
I think the tricky thing there is, I don't know that I would say staff opted to keep her. I think we had, like, she has to be kept because she doesn't have a legal caregiver who is willing to take her. Like, the decision maker and then the home that she lives and then the hospital are sort of like multiple different entities.
And the state doesn't have say yet.
Yeah, exactly. And so in this case, like, she has been determined from a medical perspective, she could be managed at home with the right caregivers, but there aren't the right caregivers available, and the hospital can't say, you have, like, we say you have to leave, but we can't actually escort her off the premises, which gets really, really tricky, because we can't kick her out the door.
I mean, and I've had child welfare workers say, you know, they're just in such a hard situation now, because it's not that there's just a placement shortage for these kids who have like really serious behavioral problems. There's a lack of placements for all kids in foster care right now. And so, you know, sometimes I've heard them say, I know it's not great for them to be in the hospital and we are looking, but at least they're quote safe. And we know that safe is relative term. But when I have in front of me a kid who's sitting here like in my office and needs somewhere to go and has no placement, that's going to have to take priority to finding the placement for this kid. And so it does become kind of this vicious cycle of, well, yes, they're not safe in our eyes, but in the scheme of things, maybe they are safer.
I was wondering, is it possible that the fact that the state's saving money during, if they're not paying the hospital, they're not a ward of the state yet, so they're saving money. Is it possible that this becomes a disincentive for the state to figure out a solution? Or am I being too negative about the states?
They're willing to pay, I'm sorry, they're willing to pay, we don't have a way to make
To build
that
it?
happen.
Okay.
There's like,
Yeah.
Oh, do you want to go there?
You got it.
Okay, I understand the question, but I think that the people that are most involved are not affected by that disincentive. Now, whether it impacts state level recruitment or state level initiation of creation of additional like state run programs. Maybe if there was a substantial, but it would have to be a very substantial monetary hit to the state for it to lead to basically creation of possibly hundreds of additional residential level beds. And nationally, the move is away from that. So this is something that is seen nationwide. And I think is largely the result of systemic changes in how children are cared for in the foster care system, but also sort of deinstitutionalization across the across all ages.
I will say that making them wait until they find a placement to then bring them into care is purposeful, and it is so that their numbers don't look, their maintenance things, you know, boarding doesn't look as bad as it is. But I don't think it's the money piece. I think it's more the how the local agencies look in the state side.
And also how the courts manage
Yes.
when they're willing to
It's
consider a
interesting,
child.
they can put a child in care in a day when they want to.
It's also become challenging, not just for these kids, but like that whole concept that nobody's stepping in, like the state won't step in while they're here when you're doing decision making. So like if medical decisions have to come up for these children, whether it's these kids or you've got kids in the NICU or other places, and there's not a decision maker for them or somebody who's actually looking out for these kids. And I think then what happens is like we come up with a lot of ethical challenges related to these kids in general. So this issue that they're not taking over custody because they're safe here and they don't yet need a placement is a really, seems to have a backward thing. Like if a kid does not have somebody looking out for them, it seems like they need somebody to step in at that moment to be the person who's going to have a responsibility to be looking out for them.
And then super quick, and I know there's a couple comments too, financially, and I'm not gonna pretend to know anything about finances, right? I'm a psychologist, I don't know anything other than the only mechanism that I'm aware of for the hospital to receive money is through billing insurance, and then we have the state capitation system in Maryland that creates this like level of trickiness at higher level that I don't fully understand, but I know it does influence how much money the hospital can receive through insurance, and the only way to bill right now for services for these kids, or like the only way to receive money for these kids is through billing their insurance, which is through, you know, MA. And I know there were a couple comments.
Hi, yes, sorry, now we've moved on to this little out of context, from when I first thought about it, I do apologize, but I think you guys make such a good case that highlights an ethical dilemma where there's gonna be harm everywhere, like patient, family, staff, like harm cannot be avoided here, and that is, in my mind, the definition of an ethical dilemma, so very good case, and also I think reflects the hardness of what you identified in the nation we are experiencing right now, is that harm can't be avoided anywhere, and we have to choose how to balance that and handle that in the ways that we can. And so onto the idea about staff distress and staff harm, and that they didn't actually choose that this is the least amount of harm for them. But I feel the other side where we have discharged kids in what we thought was the safest that we could have, and it was not an ideal situation, and they've actually come back dead a few days later, weeks later, and that is a very different staff harm that plug in for your EHP colleagues here. Or EAP, because that's the other thing too, is that yes, this is hard for staff now, but also discharging kids in ways that they experience harm on the outside and come in sicker than they left is a different burden, but also hard for us to hold. So just recognizing that there is no ideal here, and we just have to kind of work together to do the best that we can. But anyway, that we're just that. So yay, employee assistance program.
Can I just throw something out? As I'm thinking about this, comments about reimbursement and so on, the HSDRC established a method for making sure hospitals are financially managed appropriately and they don't fail. On the other hand, there's always criticism about big institutions, not-for-profit institutions, not fulfilling the obligation to the community commensurate with the benefit that they get from the state and other services. Should we be expecting more of our institutions to create programs, outpatient programs or whatever, on their own dime, so to speak, as a gesture toward fulfilling that obligation as a not-for-profit, but also to solve a problem that is distressing to everyone, the patients, the staff, and everyone else, and sort of not look to the state solely as the responsible party, but we, as citizens and entities benefiting from our not-for-profit status, using that to create programs that might help kids like this. Is that a valid thing to offer or suggest?
I think it is, and we have.
We have, did you say?
Yeah, we have. I mean, the change that we've done over the past 2 years has been really significant with the way we treat these kids. So we don't let them stay in the ED. We move them to a floor. We wrap services around our social workers around. We created what we had to create from a lack of resource perspective, and we can see that in Mackenzie and Eric's work and all of us. So I'm very proud of this hospital and the way it's responded and had to respond. And like all of us, right? Social workers, there are a lot of social workers, case managers here, but the amount of time when you can, Minnie's the expert in these kids, right? That one child in this takes far surpasses anything else. So we have, and I think you're right. I think we have to look at ourselves. I think that's the difference that happened in the past year. We started to look at ourselves and think, how do we do this differently? Because we're not going to get what we need from all these other places for all these other reasons. And the only thing you can change is yourself, right? And so we've done that. Best I can.
I think it's interesting to consider the possibility of community-based programs that are created by the institution. So it's happened with other sorts of clinics that don't fill. So for instance, the adult emergency department that has follow-up care for people that are uninsured, uninsurable, or who, for whatever reason, have difficulty following up with a primary care clinic. There are hospitals in other states that, of course, elude me at the moment, but who have set up for very high utilization adult, for instance, homeless individuals, where they put them in housing with wraparound programs, and it is less expensive for the institution. It's also better care. I'm not sure that the better care is the primary motivator, but it goes back to what may affect change and availability of beds for sick children in the ED and on inpatient units is an important consideration, but I think it is, and in the ethics committee meetings, it has been a discussion on a number of occasions about various different populations, but what is our institutional responsibility to meet an unmet need in the community, given all of the things you mentioned.
That's quite reassuring.
I wanted to see, when I'm watching the time, I want to give Kenzie a little bit of time to talk about particularly program, and then also to hear more about the employee assistance program, because and then what's going on the state level, just so that we kind of can hear what actually is happening. Because I think there is, again, I want to hear positives as well.
Absolutely. Now, the first thing, like, just a little bit of a caveat, this is still like a work in progress. There's nothing like processed, not processed, but published. And many of you in the crowd have been involved in developing this pathway. So it has been a massive multidisciplinary effort across the emergency room, across psychiatry, across the medical floors. So just like a kudos to everybody involved. So just like Rachel was mentioning, you know, this problem initially started in the emergency department. And so the emergency department had to create some decision-making criteria around like, how do we support youth who were living in our emergency department waiting for a place to live. And then when the decision to move these youth to the medical floors and sort of share the burden or share kind of the moral stress and responsibility for these youth, we then have to create a broader sort of work group to address kind of the presenting concerns. So over the summer, we met for the first time in July, and we met a couple of times since then, and we're about at our last sort of workshop to fine tune some things. But we kind of met and got representatives who shared their concerns, who shared kind of where we thought the needs were in order to care for these youth. When we identified the areas of concern, we also identified potential solutions, and then work groups were kind of established in smaller areas to develop potential solutions for the different areas of concern. And I'm happy to answer more specifics that I can at the moment. Again, a lot of these are like works in progress. And then here at the end of the month, we're meeting again to sort of like fine tune some things and to start putting something out. This includes standardizing how we're meeting with these youth who are attending these meetings, standardizing what information do we need to receive about these youth to provide the best care in our hospital, including any prior assessment information that we have, standardizing access to our mental health supports that are in the hospital, additional staff training and supports, developing a clear clinical pathway that allows a lot of the decision making that's being done sort of on the fly, or sort of this is what's happening and what we have available, and creating more standards around that, and then so much more. So that's coming down very, very soon around the pipe. That's currently what we're working for. This also includes Like a sub-work group walked the hospital space to see what are safe spaces, what do we need to do to our outside spaces to make them safer. We have looked at, like the courtyard, a couple spaces in the courtyard, we've looked at right out here out front. We've taken a look at some hallways upstairs, like on the 12th floor, to see what can be usable. We've obtained some money in order to be able to purchase items that we think will help improve sort of the quality of life for these youth, which we think will help improve the safety of staff and our patients and visitors. We've taken a look at how do we partner around our security colleagues and help them feel more supported in their role in terms of what they're doing at bedside with patients. Trying to think what else would be helpful for this work group or for this group here to know. Oh, yes. Yeah, we work, thank you. It's like, there's one thing, and it's actually like, what I like to do. We've looked at standardizing behavioral expectations for these youth so that like decisions don't have to be made by a particular nurse or staff member at a particular moment in time. So taking a lot of the decision making and also creating a space that allows as much positive behavior from youth as possible, as well as when and how to develop individualized behavior plans, what are some areas that we can support them in earning rewards, and just really having an overall improved quality of life. This looks at things like food and activity and so on. I see there's a question in the back.
First of all, thank you. Those are amazing efforts. Oh, gosh.
It's been a multidisciplinary effort, so I'll have one things.
Colleague of Rachel's on the adult side, and so I guess my question is, in all those wonderful action plans, will that transition over into the adult unit? So it's very rare we have a use on the adult unit. It has happened. I anticipate it's gonna continue to happen, and I'm hoping that some of those wonderful standardizations might cross over, and how we can partner with you and be a part of that.
So the best answer that I can have to that question at this time, it's a really, really good one, is that the work group has had that conversation, and we're at the stages of figuring out how to make it work within the confines of the children's center at the moment. And then there would have to be discussions on what this looks like outside of the children's center for the rest of the hospital. So it's definitely been part of the conversation.
I think the question they've asked us is, can they transfer the children, right? And so that goes back to ethical duty to the right thing, who's willing to take the. Yeah, it's a good question.
And I wish I could answer that question.
She was saying that there was a question of whether or not like the children
Can move into
the older like 19-20-year-olds.
they're not 19.
So they end up on the SIAD or like a different floor, like outside of the children's center, then they transfer here. And like when they transfer into the children's center to access what we're working on developing, or like how does this look in terms of reaching out, what the children's center is looking to develop to the other medical floors out.
Those are really nursing questions.
And those are just really, really good, really big questions and have been part of the conversation, but I don't have any particular answer.
Can I ask a diverting question, maybe of a psychiatrist and neuroscientist who might be in the room? That being, what are the prospects for psychedelics or hallucinogenics as therapeutic interventions that might alter the course of illness in kids?
We're not gonna go there now.
I think we're not there yet.
Are you referring to what they're doing with adults currently?
Pardon me?
Are you referring to the studies with adults they're doing currently? Yeah.
Well, I'm wondering what, I don't know the results. I mean, in depression and things like that, there's
We're
shown some value, but
No,
No.
I'm under 18.
Yeah. I mean, I think that's.
It's a really good ethical question. I would say the question is, are we medicating them to make them easier to manage, or are we helping support the management of their pre-existing mental health question, which is like a really big topic.
You don't have to.
The one other thing I was gonna say, and I don't know, is the other thing that I've seen a shift. I think years ago, we saw our role as, does the person have to be here, yes or no? And then while they're here, how do we make it better for ourselves? And I think these conversations with the state, there's been more of an effort to think about what can we do while the kids here to make it easier to find a placement and have those conversations with the people who are being nice. There's somebody behind me that's asking.
Yes, hi. The question about if the work group has looked at best practices at other institutions, the kinds of things they've done and what to do.
Yeah, so this is a super good question. The direct answer is yes, we look at what other hospitals are doing. The very tricky answer to that is that other than Rachel and some of her colleagues, there's not much published on it. So it's a little bit of like reaching out to friends and, yeah.
She said
Other than you, yeah. We reached out to lots of different colleagues at lots of different hospitals at many different states to see like what are they doing. And like we've mentioned before, this is a nationwide issue, and also people are still actively figuring it out as well. So there are no answers available. So
There was a recent article in the New Yorker about what's being done in, I think it was New Jersey, which has some interesting ideas on it.
Want to talk about PhD? Can I just, I want to add one more good thing that we're doing that we can be, on top of this is our weekly calls with DSS. So DSS is assigned a hospital liaison position, and they bring on all the representatives, make them accountable, and we speak to them every week about it. So.
Case by case,
Yeah.
individual.
Okay, yeah, I think that's like a transition I've got like.
Yeah, so we are the employee assistance program. We have rebranded multiple times since I've been here. So we used to be known as FASAP and then My Support, and now we are just the EAP, which we colloquially kind of call ourselves CHIEF. We can provide kind of multiple touches of care. So it could be conducting kind of a critical incident stress debriefing, particularly after a really difficult case. We could use the Everly or the Everly Mitchell model to help kind of debrief and process what has just been experienced on the unit. We also do a lot with RISE, and also if the unit is struggling due to any sort of a difficult case, we can swing by with RISE, and they have kind of their goodie cart with snacks and tchotchkes. And that's just kind of a way to get people to us so that we can let people know what we do and to please come and see us. That this doesn't have to be, a painful experience coming to see us. Then we have our on-site clinical team. And so I'm an employee of Hopkins, just like you are. They sign my paychecks. I think sometimes it can be really beneficial seeing the on-site clinical team because we are very aware of the realities that come from working at Hopkins. And we are available in person. We have people stationed. We have someone at Bayview. We have a couple of people here on the medical campus. We have people at Eastern. So we're available in person, virtually, and also telephonically. And so we really try and make ourselves available in any way that we can. Now, some people might say, speaking to someone who is also employed by the institution that I work for isn't really something that I'm comfortable with. If you contact us, we can also help to get you connected with an EAP clinician in the community so that there are a couple more degrees of separation. Additionally, we provide in-the-moment support. So it could be 2:30 in the morning and something really difficult could have happened, and whether you're here at the hospital or whether you're at home and you can't sleep, you can give our number a call, let them know that you work for Johns Hopkins and that you're looking for in-the-moment support. That's kind of the key word, and you can be connected to a clinician almost immediately. We are ramping up to kind of our busy season, but we usually can get people in to see us within 3 days, which is a big change from what it used to be years ago. And that's a really wonderful change, so people don't have to sit with stress. Obviously, with difficult cases, not only does that have an effect on how we show up at the hospital and interact with our clients and our coworkers, but life doesn't stop when we leave the hospital. Some of us are wearing multiple hats here, but we also might be wearing multiple hats at home, and stress can manifest differently for different people. So whether that's physically or difficulty with appetite, or sleep, or regulating our own emotions. We also just provide a place to process any sort of moral distress or moral injury that can come from dealing with these difficult cases. And our goal is not only to provide a safe place for people to be able to talk about this, a safe and confidential place, but to help improve wellness. So not just kind of life vest skills to help get you through the day, but to really help to set up a robust support network so that you can feel like you can continue showing up as your best self at work.
So can I just add one, I just want to make sure. These are the kinds of cases that actually really accumulate weight on us as clinicians, as people. And it may not be that you have an acute event, but you notice over time that you're developing anxiety and depression and really not feeling like there's a life or feeling numb. I think there's a place for processing, cases. We do that as members of the ethics committee, RISE school. But there may be times when you really need some mental health support. And I think it's important for us to know that these resources are available to us and that it's not a failure on our part if we get to that point because of just the very things we've been talking about here. So just to know that those resources are here. When the basic things don't quite meet our needs, there's more that we can access. The other thing I want to make sure we distinguish, not all distress is moral in nature. And so it's really important that we distinguish where the distress is coming from and we meet it with the right kinds of responses. Because what we're going to offer in terms of our moral discomfort and distress may be different than generalized stress and distress. And it may be all those things, but I think we need to not lump everything together into one bucket because it's usually a lot more complex.
And I wanted to, say again, I know years ago when I was in medical school, like you were tough, you were sick, you still were at work, there was like that, we're here, we're the tough people. And I hope that over time, I think we do our patients a disservice by having that attitude. And I think by reaching out and getting these services, we actually hear for our patients, but also can model that for our coworkers, for each other. And I think that goes down to our patients. I think we can take better care of our patients when we are using these services. So I think to even create that system where this is not just if I'm totally at the end of my rope, I call, but what we call on a more regular basis and use the service.
Yeah, and people can come to see us for 6 sessions per issue. So it's not just that you get 6 sessions during your lifetime here at Hopkins, but that if something happens, you can come in and get 6 sessions. And then a couple months down the road, if something else happens, you can come back and see us for 6 more sessions. And there's no limit. Whether that's life stressors, things that are happening on the unit, diagnosable mental health concerns. We all on staff can diagnose, and in previous lives or careers, many of us have. In this role, we don't diagnose, but we can help to point you in the right direction to help make sure that you're getting the appropriate amount of support that you need.
Right, well, I want to thank our panel and thank all of you too for taking, it sounds like many of you, not surprisingly, take care of a lot of these issues. I think these youth are definitely it takes a village. It takes a village to have any one of these youth on our unit takes a lot of people taking care of that. And so I think having these conversations is really important. So I really appreciate everybody coming here and hearing about this. And I appreciate all the panel.